Okay, so hopefully everyone's had a chance to put an answer in. And I'm glad that sort of it's looking reasonable. So obviously the answer is not C. So we're talking about sort of what are the fastest types of pain propagation. So this would have been like the quiz we'd have had on, well, the poll everywhere we'd have had on Friday if you hadn't already just had an exam. So when we're talking about pain propagation, it's going, you know, like there's different types of fibers that transmit that sort of painful stimulus to the spinal cord. And so the fastest types of pain, as you kind of remember, are sort of sharp pricking pain. And there is a subset of thermal pain that also gets transmitted quickly. But the very fastest transmission of sensation is actually just normal touch. And this is why, for example, you know, like if you touch something like this desk, you feel it instantly. Whereas if you touch something that's actually painfully hot, then there's just that fraction of a second that allows you to sort of, you know, get that big blister on the end of your finger before you move it away. So the answer for this one is in fact A. And so now we'll quickly finish up a discussion of headaches. And the very last type of headache we'll talk about is cluster headaches. And they are relatively rare. They're much less common than, say, migraine headaches. But they are characterized by a specific set of symptoms. And they're also, in patients when they occur, they can be extremely debilitating for those patients. So the pain in cluster headaches is very characteristically localized to sort of kind of an orbital region. So the back of one or other of the eyes is almost never going to be bilateral. And the pain is very severe and typically lasts between 15 minutes and about, you know, like up to sort of maybe about 3 hours. They have this other feature, which is they're commonly associated with autonomic symptoms. So, you know, like nose running, eye running, things like that, specifically on the ipsilateral side. And typically, the reason they're called cluster headaches is because they occur in, you know, clusters. And typically, they'll occur like more or less exactly the same time every day during the sort of cluster period. So, and that can be sort of a period of sort of weeks or even a couple of months, where every day at that particular time they're having this really severe, debilitating headache. And it's most common in men between the ages of sort of, you know, 20 or 40 or so. So, what is the pathophysiology of cluster headaches? Well, it's not really understood. It is thought to involve the hypothalamus, however, and that kind of makes sense because the hypothalamus is one of the functions of the hypothalamus is the regulation of the circadian rhythm, so the day-night rhythm that we'll be talking a little bit about. I think it's probably next week we talk about sleep. So you can see localize this sort of region as being sort of abnormal in patients who have cluster headaches. And another aspect of the pathophysiology that has been observed is that sometimes you'll find cluster headaches being called histamine headaches. And that's because in patients who suffer from cluster headaches, low doses of histamine will often induce these cluster headaches. However, unfortunately, antihistamines aren't effective at all in treating them. So there seems to be some ability to sort of trigger the headache by a histamine, but other than that, it's like not really related to histamine. So there's some simple diagnostic criteria, which are the severe periorbital headache, at least one ipsilateral autonomic feature, the characteristic period of 15 minutes to 3 hours per headache if it's untreated, and at least 1 episode every other day, up to 8 episodes per day, which would be like unusually severe, but can happen. And then has to be unilateral, and it's this sort of very severe level of headache pain. For treatment, there's a lot of overlap with migraine treatment. So we're using serotonin antagonists, serotonin agonists, I'm sorry, to cause vasoconstriction, because that seems to be involved in the pain. Some local anesthetic nose drops can also often be effective. And sort of slightly unusual treatment is that oxygen is also often an effective treatment for sort of reducing the severity of the pain. And obviously oxygen tends not to have too much in the way of side effects and so on. So as far as prevention of cluster headaches, we're looking at voltage-dependent calcium channel blockers. So this is these you'll come across typically as blood pressure medications, but they can be effective. Anti-inflammatories like corticosteroids. Lithium carbonate is sometimes used. It's a common treatment for as a mood stabilizer, but it does seem to have some effectiveness in cluster headaches. And then there's some anticonvulsant drugs like topiramate that are used, and sometimes you can there's actually direct injection of, for example, methylprednisolone into the nerve itself in order to sort of reduce the inflammation and reduce the pain. And this can sometimes, for people who have severe cluster headaches, can be an effective treatment, because although getting a giant needle stuck in your eye isn't the nicest thing in the world, getting rid of the headaches is obviously a major plus. So the very final sort of like kind of side note for headaches is, and something that you'll come across a lot as pharmacists, is medication overuse headaches. And so this is an example of, like why we're careful about, like recommendations for people, like taking painkillers. So these can occur for a large number of different types of analgesics. But things like opiates and barbiturate combinations are particularly prone to develop, to give people these medication overuse headaches. But even sort of something like taking excess ibuprofen for sort of too long, when you stop, can lead to this kind of rebound headache. It typically happens when people have been using analgesics for more than 15 days per month. Or some of these other drugs for more than 10 days per month. And the reason it's sort of such an issue is obviously if you're sort of starting to develop headaches from your painkillers, then like you're really never going to be able to sort of like solve the headache itself. It's not really clear how this occurs. It's thought to be related to serotonergic neurotransmission, but it's like it's one of those things that's kind of difficult to study. But what you see in these patients who have like ended up taking these sort of analgesics for long periods of time is that they get chronic daily headaches, and then that of course leads them to needing some other kind of medication to sort of try and help with the headaches. So this is why it's one of the reasons why it's important to look at the use of different analgesics. Yes. So when you say medication overuse for headache, that sounds like a quiz, an exam week question. No. The pathology of migraines? Yeah. We covered that last Friday, but this is the sort of main slide on migraine pathology. So where we're talking about the role of the trigeminal nerve, and it gets involved in this sort of wind-up process where it's the nerve itself becomes overactive, and that leads to all of the excessive vasodilation of the arteries. And then there's a second stage where you're actually inducing changes in the thalamus that are basically enhancing the sort of experience of the pain. And the in particular, sort of probably the CGRP is probably the most important of the messengers that are involved in this process for you to remember, just because those are that new class of anti-migraine medication that's just been approved this year. Yes. Yeah. So I think you can probably get a psychogenic headache, but all of the headaches that I'm talking about have like an identifiable physical aspect to them. So like tension headache is down to the sort of excess activation of the muscles that are sort of involved in the head. You know, migraines are involved in the blood vessels. Cluster headaches are also probably, well, involve like specific inflammation, like at the sort of base of the sort of optic nerve and so on. So they all have like some level of, you know, like sinusitis, you know, like leads to, you know, like that kind of headache, sinus headache. So that all of these ones have some underlying physical cause that you can identify, but they're not secondary to some other issue like, you know, brain injury or something. So at that point, yes.
So it wouldn't be secondary to sinusitis?
So that is a,
Like a sinus infection?
yes, I would say that that would be, so sinus headache is often classed as a headache, but yes, it's secondary to a sinus infection for sure. So it's like sometimes you have these clear definitions, but when you sort of poke at them, you can find sort of like little bits on the border where it kind of is like a little fuzzy. And that's because everyone likes clear definitions. And so that is then leading us into a different type of headache, which is headaches coming from brain trauma and stroke. And we're going to start off by talking a little bit about traumatic brain injuries. And so these are extremely common. And so the estimate is that there's sort of 1.7 million TBIs per year in the US, of whom 52,000 will die. And so it's, you know, like it's obviously not a chronic disease state, it's an acute trauma. And so there's lots of causes of TBI. And I think probably the one we think of most often are going to be things like motor vehicle accidents, because obviously that's a very easy way to get a severe head injury. And 17% of reported TBIs do come from car accidents. About a third of them come from falls, and this is particularly the case, obviously, for the elderly, where they're obviously more vulnerable to falls. About 16% are due to sort of, you know, like some kind of, you know, like presumably accidental striking of an object striking the head. And about 10% are actually from assaults, which is a little alarmingly high, really. This is sort of like a relatively common problem. And it's also something that you've sort of come across a lot in sports. So, for example, I don't know if anyone saw the Cowboys game yesterday. In that game, Dak Prescott was tackled and hit in the head, and you could see his eyes go for a second, and they sort of took him off the field for concussion protocol, and he was let back on the field. But I mean, in my opinion, he clearly shouldn't, because he clearly had some, like significant concussion. Like he was able to play, he was not dizzy and so on, but clearly he had some injury. And when you have a concussion, as we'll talk about, there is a long-term additional risk of further exacerbation of that injury, which is the whole purpose of the concussion protocol, is to sort of get people before they have any sort of major injury and sort of kind of wrap them in cotton wool whilst the brain can recover. And actually, and there's, what's his name? Dale Earnhardt Jr., the now retired NASCAR driver, has some sort of interesting stories about being involved in, obviously, some of these horrific car crashes, and then sort of like having, like these sort of headaches, and then being sort of terrified to go to his next race because he knows that there's a chance of another crash. And so, like, that was in the end why he called time on his career, because he sort of realized that this was starting to become a major issue. So these things, like, you can, if you're involved in an activity that carries this kind of risk, it's something that you need to sort of be aware of or talk to people about, just because one minor concussion typically doesn't have any bad consequences. But when you get repeated ones, the more you have, the more severe the consequences become. And the way in which concussions are assessed, like in the emergency room, for example, is through this Glasgow Coma Scale. And as you guess from the name of it, the most severe types of traumatic brain injuries are obviously going to result in someone in a coma. And there's three basic aspects that you look at with a patient for this coma scale. So we have motor response, verbal response, and eye opening. And so, motor response, obviously, so the way in which the scoring is done is that the patient can, like get, for example, up to a score of up to 6 for the motor response, where 6 is the best, up to 5 for verbal response, and up to 4 for eye opening. In all cases, 1 is the worst. So if you get 1, 1, 1, you're in a coma. However, sort of the motor response, like it's breaking down, sort of like, obviously if someone can fully move around in any way that you ask them to, then that's good. However, they might be sort of barely conscious. How would you assess their sort of motor response in that situation? Well, you do some kind of noxious stimulus to the patient, and if they have a reflex response to that that's appropriate, then that's good, good. So if they can localize the noxious stimulus, that's nearly good. If they can withdraw from all they can do is withdraw from a noxious stimulus, it's still better than it could be. Then we have these two types of abnormal movements. And so these are sort of decorticate posturing and decerebrate posturing. Yes. So it can be anything from like a pinch or something like that, just something that, like not, like stabbing them or anything like that. But in some cases, you might be giving them an IV, which would qualify as being a noxious stimulus, because, like, no one really likes having IVs, or at least I don't. So, but these examples, these decorticate and decerebrate posturing, are obviously a particularly bad sign, because they really do indicate that sort of some major damage has occurred. And in the case of the decorticate posturing, it basically means that aspects of the cerebral cortex have been have at least been functionally separated from the body. So that gives rise to this. This is a little cartoon of the kind of decorticate posturing of the patient. Yes. Yes, it's like that will be how they'll kind of like, they'll generate this kind of rigidity, because essentially the in this case the sort of motor cortex has been separated in some fashion from the body, which doesn't mean it's sort of like gone. It can be sort of like you've got some like swelling that's putting pressure on a nerve or something like that. It doesn't necessarily mean that they're like doomed. But
when people go stiff after getting knocked out, is that what it is?
I haven't actually seen that. So
There's a lot of combat sports. I've seen people do some crazy things after getting knocked out, from going full tetanus to hurling into a ball.
so most of that is probably some level of seizure, I think. But like it sounds more like seizures. So, but and then this decerebrate posturing, which I think everyone would kind of recognize as sort of being like kind of bad, where you're kind of bending like this, is that's more severe and means that there's sort of damage at the level of the brainstem, which is obviously, since we've talked about the importance of the brainstem in controlling so many different things, is never going to be a good thing. So what are we talking about for verbal responses? So that's when you're sort of like talking to the patient. So like if you're talking to the patient and they like know where they are, if they're sort of alert and orientated in sort of like time and space and person and so on, that's like always a good sign, even if they sort of look like like have a gigantic wound gushing blood out of the head. If they can still talk clearly and coherently, then that's an excellent sign. If they're confused but still coherent, like so they might be kind of rambly or not really making any sense, but they're proper words and so on, that's like they're now starting to sort of go down this scale. If they're using inappropriate words and just jumbled random sounds and so on, jumbled random words, that's worse. Random sounds are worse again. And obviously unable to sort of vocalize at all is like right at the bottom. Eye opening, obviously being able to spontaneously open your eyes is a good thing. Then there's opening only when spoken to, and then opening only to pain, and then obviously unable to open your eyes. So you can kind of see how like no response, no sounds, no eye opening is what a coma is. So I really want you to sort of like kind of know what the best and the worst examples are, and sort of like that you have these three components and so on. So if like it's one of those things, it's sort of we could easily have an entire sort of couple of lectures on traumatic brain injuries, for example. But if we don't do that, then I think it's unfair to expect you to sort of go through all of this at that level of detail. So that's why just the general concepts of the three different areas in the best and worst case scenarios. And so the scoring is obviously you have the sort of 6, 5, and 4 in order to give you build up your GCS score. And so if you score 15, then like that's what any of you right now would be scoring. If you scored like a 3, that's like when you're in the coma because you're unable to do anything basically. If you're in a coma, that doesn't necessarily mean that there's like no hope for the patient. In many cases, sort of like if you're sort of in this if you're in medically induced coma, that's its own thing anyway. But even if you're in a coma, you're by definition fully unconscious, and therefore because by virtue of that, you're unable to respond. So there probably are situations where a slightly higher than 3 score might actually be worse than a 3 score, simply because by virtue of being unconscious, it's sort of masking any other kinds of symptoms. And then we have, like sort of different levels of disability that are being scored in this fashion. So how do we get why do we care about TBIs, and sort of why do we, like how does damage actually occur to the nervous system? So there's two basic types of primary traumatic brain injury. So there's the actual classic one that you'll probably all have already visualized, which is like when the head hits something hard. And in that case, you get the sort of the brain tissue that will be most likely to be injured is going to be at the site of the impact. You can also get non-impact head injuries, however, or traumatic brain injuries. And this is where you have the sort of, this is similar to whiplash injuries. So, whiplash is primarily like an injury to the neck, but in the same kind of way, if a head has to go back and forth very fast and violently, then there's going to be an impact essentially between the brain and the skull. And that's going to be at both ends of the brain, because it's going to go against the skull that way and it's going against the skull that way. So that's a non-impact type of brain injury. And in general, for single severe traumatic brain injuries, you're going to see fairly immediate impacts. So there's obviously going to be, like the pain, potentially confusion, things like that. And then any complications that arise, and by sort of complications is essentially sort of, mid to long term, like signs of mid to long term damage are going to be usually evident, right, like very quickly after the injury. So these can vary from like the most mild sort of like persistent headache, but they go all the way obviously through different types of sort of neurocognitive things, like confusion, things like that. They're generally down to localized swelling of portions of the brain. In some cases, you can obviously, for severe traumatic brain injuries, you can get intracerebral hemorrhages, and you also can get shearing of white matter, sort of axon bundles. If you have a depressed skull fracture, that's obviously doesn't just add the complication of the broken bone, but obviously has something sharp that's potentially poking into the brain matter. And so that's obviously going to be an additional factor. In many cases, it sort of becomes important to operate to try and remove the pieces of bone quickly. It also obviously risks damage of, increases the risk of ischemia for some of the brain regions, because they're going to be sort of either cut off from blood or actually sort of soaked in blood, which will lead to their own particular types of damage to the neural tissue. These, although a closed head TBI, i.e. where you don't see any sign of damage to the brain or the skull, those actually, they can be hard to treat, but they often do give rise to sort of long-term symptoms. And so these can be sort of, chronic headaches, dizziness, vertigo, this kind of thing. So there's a physical trauma that occurs in a traumatic brain injury, but there's also a physiological trauma, which is what is the one of the fundamental causes of the actual damage to the neural tissue. And this is something that's actually, this mechanism of damage is the same as the mechanism of neuronal damage that occurs in things like stroke. So what happens when you have damage to neural tissue is that you get changes in the membrane potential of the neurons. And the reason you get that is that you tend to get a big release of excitatory neurotransmitters due to the sort of swelling and the shock. When that happens, obviously these are excitatory neurotransmitters, and glutamate in particular. And so we get depolarization of huge numbers of neurons. So, there's widespread depolarization. And it's not like just ticking along like it would be for normal, synaptic transmission. This is sort of like dumping it. And so that means that we're collapsing the membrane potential of large numbers of neurons. And so when that happens, obviously the neurons step up their efforts to sort of restore their ionic gradients, which means they're burning through lots and lots of ATP. And they still have a messed up membrane potential, and now they're running out of ATP. And so when neurons lose ATP, then they go into, that's one of the triggers for neuronal cell death. And so that leads to neurons then dying. And obviously, you're probably aware that neurons, although we do have newborn neurons, we don't make very many of them. And so when you start getting large-scale die-offs of your neurons, then that's long-term irreversible brain damage. So, yes. Yes. But if you have these sort of, oh, I see from this little cartoon up here. Is that what you're talking about? Yes, that's if you look at if you think about that as EEG rather than action potentials, it would make more sense. Like, so there's more synchronous depolarization of neurons, but action potentials themselves, yes, are all exactly the same size, and I would not have drawn it like that. But I didn't draw it, as you can tell by the fact it looks pretty, rather than disastrous. So it's also a little funky looking for an action potential too, but there we go. But yes, so the fundamental issue is going to be collapse of the membrane potential and the ionic gradients, leading to loss of ATP, also leading to swelling of the cells. And because then they can swell and they can burst, which is even worse than programmed cell death. Because when they burst, there's no regulated process and there's just everything kind of dumped out, which is a very strong pro-inflammatory signal, which will then lead to more swelling and lead to more damage. Because when you're swelling the brain, it's obviously sitting in its nice little sort of box of the skull. And the skull is great for protecting the brain, except from like the inside, because if the pressure builds up in the inside, then it has nowhere to go. We don't have like bits of the skull that sort of stretch. It's like it is literally a closed box. So you swell, you start putting pressure on the nerves that are coming out, but you also lead to damage of the neurons just directly by compressing them, essentially. So we have all these multiple types of damage, like swelling-based, ionic-based, and energy depletion-based, leading to loss of neurons in various ways. As far as treatments for TBIs, obviously, emergency treatment is to some extent limited, but is certainly urgent. And so you need to sort of basically restore oxygen perfusion to as much of the neural tissue as you can, which, like whether you're going to sort of be giving patients oxygen or whether you have to do something to relieve the pressure. Any kind of bleeding in the brain will absolutely require urgent surgery. And there are often you'll give patients hyperosmolar IVs in order to reduce the pressure in the brain. And we've already introduced this idea that there's such a thing as athletic traumatic brain injuries. So like where athletes and, like football players are probably the poster children of for this disease. Though it was first recognized in boxers, and when it was called dementia pugilistica, and now it's obviously known as chronic traumatic encephalopathy. And what you see in these patients is that they develop a sort of progressive neurological issues. And so typically these are associated with dementia, tremors, and localized neurological deficits. Yes? Parkinson's. No, he's Parkinson's. But however, it could be related, because there are when we talk about Parkinson's, I think I'm pretty sure I have a slide about the similarities and differences between CTE and Parkinson's in terms, like at the tissue specimen level. But there are features within the brain that they develop these tangles and Lewy bodies and so on, which are associated with some neurological conditions like Alzheimer's and Parkinson's and so on. And they develop in the brains of people who've been exposed to these chronic, repeated, very mild TBIs. So, for example, in boxing, like someone is continually obviously being whacked in the head, and similarly in American football, the what's thought to be the major driving force for the development of CTEs is actually thought to be practice rather than the games themselves. So in games, like you do get these sort of severe head contacts, which can be very serious. But in practices, they're doing sort of milder ones, like many, many times. And it's actually that mild repetition of the sort of shocks that often gives rise to this seems to give rise to the development of these buildup of misfolded proteins and so on, which will eventually lead to this kind of dementia and so on. Yes. So that's a good question. So as far as compensation goes, the brain is brilliant at doing that when there's some level of damage. However, so this is why like you can have like if you are involved in a car accident, have a severe head injury, like terrible. However, there's a good chance that you would be able to regain full function. This kind of repeated sort of mild injury, however, is leading to sort of buildup of like toxic peptides, essentially, sort of in your brain, and that can't be compensated for, because it's actually you're creating this long-term damage that will just build up and get worse and worse. And if you stop the process of that, then there's every chance that it will won't get worse. So there is a huge amount of compensation that goes on in the brain, where it can sort of you have plasticity at the level of individual synapses, and you have plasticity at the level of being able to grow new connections and so on. And that's why we're able to, people are often able to recover from serious brain injuries. There's even some level of compensation where people can essentially lose a chunk of certain aspects of the brain, bits of the brain. And over time, they can learn to control those same functions with other bits of the brain. So I'm going to skip the talking bit, and so we can get going, because I'd like to get through some of this stroke portion, especially since we have to get through epilepsy tomorrow, which is also not one of the shortest classes. So we've talked about traumatic brain injuries. They have a lot in common with strokes. Sort of obviously the like initial insult is going to be different, because strokes are essentially related in some fashion to the blood supplies to the brain. And so to talk about strokes, we need some specific terms. And so we have these definitions here. So ischemia is the process, is what it's called when a particular part of the body basically loses its blood supply, or loses its oxygen supply. And so it's cerebral ischemia if we're talking about the brain. And obviously, if you the brain runs out of its sort of oxygen supply, it loses the ability to make ATP, and that's what can cause those same cellular changes that we talked about in traumatic brain injuries. If a portion of the brain loses its blood supply for more than a couple of minutes, it's called an infarct or an infarction. So another term that you will want to know. And that will lead to this neuronal death in that affected area. There's also a common thing called a TIA, which is a transient ischemic attack. And transient is the key word here. It means that the blood supply has been restored within a couple of minutes. And so patients, you'll hear about patients who have TIAs and patients who have strokes. And the difference is the length of the duration of the, the difference at the clinical level is the duration of the symptoms. And at the sort of neurological level, it's basically whether or not that tissue dies or not. So if the symptoms resolve within 24 hours, classically that would be regarded as a TIA and not a stroke. There may be cases where there is in fact a small infarction, so a small area where there's brain tissue has been lost. However, it's sufficiently small and localized that it's not really giving rise to symptoms. And so this is why nowadays the formal definition of a stroke is either persistent symptoms or a clear infarct in brain imaging studies. So there's, as you're probably well aware, there's a lot of risk factors involved in strokes. So the risk of having a stroke roughly doubles for each decade of life after the age of 55. But there are also some genes which are dramatically increase the risk of stroke in certain patients. There's a complicated relationship with gender, so that the stroke incidence is higher in men up to the age of 75, similar in men and women in the 75 to 84 range, and higher in women above the age of 85. The lifetime risk of stroke is higher in women, however. So calculated lifetime risk for women above the age of 55 is 21% compared to 17% for men. So it's not a huge difference, but it's noticeable. One of the biggest risk factors for stroke, other than having one of these genetically predisposing disorders, is having a TIA, a heart attack, or a prior stroke. All of these increase the risk of having a stroke by about tenfold. And in many cases, patients will have a TIA before they have a full stroke. There are also a bunch of controllable risk factors, ranging from high blood pressure, cigarette smoking, diabetes, and some level of some kind of carotid or other artery disease, like atherosclerosis. There seems to be a relationship between blood cholesterol and stroke. There are dietary factors that seem to be, that sort of may influence stroke risk. The old thing that everyone talks about with sort of keeping your salt intake down because of stroke risk is nonsense. But there's a small population of patients for whom, they don't have good regulation of salt in the body. For 99% of people, salt has no bearing on stroke risk. The studies that showed that were animal studies where rats had to eat these gigantic salt cakes. And so if you sit down to a meal of a gigantic salt cake, then yes, you probably are increasing your stroke risk. But if you don't do that, you probably don't have to worry. There's also a link between physical health and stroke, so that people who are very inactive and those who are obese are going to be at a higher risk of stroke. So a lot of this basically just comes down to sort of the blood supply, as you would expect. So strokes are, as we'll talk about, are essentially driven by some kind of failure in the blood supply to the brain. And so anything that's likely to precipitate that is going to be a problem. If you have buildup of, like the sort of fatty buildups in your arteries, it's going to be easier to block those arteries. And so that's why, like some of these risk factors, are there. It's important to know the difference between the two, like canonical types of stroke. So you can have hemorrhagic strokes and you can have ischemic strokes. Both of them involve, like the blood supply. In hemorrhagic stroke, it's the blood, you're literally bleeding in the brain. And so, whereas ischemic stroke, which is 80% of all strokes, you're blocking the blood supply to a portion of the brain. And as you would imagine, in hemorrhagic strokes, so you're bleeding directly into the brain. That causes problems with swelling. It causes damage to the tissue at the sites of the bleeding. Also, it will cause ischemia in sort of more downstream portions of the brain, like supplied by those arteries, because obviously if the blood's leaking out here, it's not perfusing the bit of brain that's over here. And so you can get, in many cases, you'll get both ischemic regions and hemorrhagic regions in a hemorrhagic stroke. There are a number of different types of ischemia that you'll see in an ischemic stroke. And so if you, for example, have a heart attack, you'll like get a problem with the blood perfusion to the brain, and that will not necessarily completely stop the blood flow, but it will obviously greatly reduce it. And obviously that will lead to syncope, so loss of consciousness. In cases where you're not getting treatment for the heart attack quickly, you can start getting, because the way the perfusion of the brain works, you have all these branching arteries that sort of perfuse little specific regions of the brain. And so in heart attack patients, if they're not getting treatment quickly enough, they'll start to form in regions of infarct initially at the sort of most sort of downstream portions of the brain. So the kind of the border zones between the different cerebral arteries. If you have really severe, sort of like your heart's completely stopped and no one's done anything about it, you start getting global hypoxia ischemia, which basically, and this is, obviously complete loss of blood supply to the brain. And as I think you could probably guess, that's not generally a good thing. And if it, would lead to death, like obviously within a couple of minutes. Yes?
So is that in general better to have
Hemorrhagic?
Yeah.
No, hemorrhagic stroke is the most life-threatening form of stroke.
I thought it's better to break out the vessel instead of blocking it.
So if the vessel bursts, then everything downstream of it has essentially going to have the same problem as if you had blocked the blood vessel, because it's, like the blood's coming out in the wrong place. And but then you're also causing all of those complications from the direct bleeding into the brain, which is going to destroy all the tissue at the site of the bleeding. So the problem with hemorrhagic stroke, well, one of the major problems with hemorrhagic stroke is it leads to this sort of large-scale increase in intracranial pressure, because it's not the veins that are bursting, it's obviously the arteries, so you're pumping blood in, and so that's leading to this buildup of pressure and the damage from the blood on the neural tissue and the sort of obviously downstream ischemia. So the hemorrhagic strokes are much more life-threatening than ischemic strokes. In general, when you have a stroke, it's going to be down to some kind of thrombosis. So you've formed a blood clot somewhere else, typically in the either in one of the proximal vessels to the brain, or in the heart. That's sort of, and then that little fragment goes up, and then it goes through the circulation until it can't fit anymore, and so then it'll block whatever small vessel it lodges in, and that's what will typically give rise to the ischemic type stroke. And so this is what's basically described here. So we have excuse me, blood vessels coming up to the brain. Any kind of clot that forms either in those blood vessels or in the heart will can come up into the cerebral blood vessels, and then if it lodges in one, then everything that's supplied by that blood vessel will then lose its oxygen supply. And so if it's a transient one, it means the blood clot is lodged, blocked, and then broken up, and then the blood supply has become reestablished. If it's a full stroke, it means it's blocked and stayed blocked for at least a few minutes, enough time for the neural tissue to start to die. And so just to sort of finish off this section, this is basically pointing out that the pathophysiology at the cellular level of the neuronal damage is going to be the same as happens in traumatic brain injuries. We're basically losing the membrane potential, with leading to neurons swelling and bursting, or neurons dying due to lack of ATP. And we'll finish this from the signs and symptoms and sort of talking briefly about some of the cerebral arteries tomorrow morning. So, because we're out of time.